Sometimes we have acute MR. That means due to certain conditions, mitral regurgitation happens suddenly. In a patient with acute MR, because the left atrium hasn't had time to adapt and hasn't enlarged, it can't handle this much blood volume coming from the left ventricle. Therefore, the physiological characteristics are somewhat different from chronic MR.
Hello, I'm Dr. Habibi, and in this video, I want to explain heart murmurs in simple and easy to understand language. So stay with me.
The letter S stands for site or location. In a patient with acute MR, just like in a chronic patient, is heard most intensely and loudly at the apex and the left sternal border. And if we want to hear the murmur better, we ask the patient to lie in the left lateral decubitus position. The letter C stands for character. In a patient with acute MR, the murmur has a blowing quality, meaning it sounds like a whooshing. The letter R stands for radiation. The radiation of the murmur caused by acute MR is variable and depends on its mechanism. As you know, the mitral valve has two leaflets, the anterior leaflet and the posterior leaflet. The anterior leaflet is positioned anterolaterally, and the posterior leaflet is positioned posteromedially. Normally, the papillary muscles and chordae tendineae are attached to the valve and its leaflets, preventing them from prolapsing back into the left atrium during systole when the left ventricle contracts. If, following an anterior myocardial infarction, the papillary muscle or the chordae tendineae attached to it rupture, it causes the anterior leaflet to prolapse into the left atrium, while the posterior leaflet remains fixed in its place. Therefore, when the left ventricle contracts, the mitral regurgitation jet is directed into the left atrium toward the posterior side by the leaflet that has prolapsed. So, the jet caused by acute mitral regurgitation in a patient with a ruptured anterior papillary muscle is heard better in the axilla and the back. But in a patient who has had a rupture of the posterior papillary muscle or the chordae tendineae, the anterior leaflet of the valve remains in place, but the posterior leaflet prolapses into the left atrium. As a result, during systole, when the left ventricle contracts, the mitral regurgitation jet is directed toward the anterior side. Therefore, the loudest and most intense murmur caused by acute mitral regurgitation in these cases is heard in the anterior area. The letter I stands for intensity. The murmur caused by acute mitral regurgitation is usually less intense. In other words, it tends to be mild to moderate. The letter P stands for screw. The murmur from acute mitral regurgitation is high-pitched or high frequency. The letter T stands for timing. The murmur caused by acute mitral regurgitation is heard louder at the beginning of systole, early systole, and then gradually decreases, not lasting until the end of systole. So, unlike chronic mitral regurgitation, which is holosystolic, the murmur from acute mitral regurgitation is early systolic. What's its characteristic? As we said, in acute MR, the left atrium is not ready and has not enlarged, and therefore, as soon as some blood is pumped from the left ventricle at the beginning of systole and enters the left atrium, the pressure in the left atrium rises, and the gradient on both sides of the valve equalizes. And this equalization of pressure on both sides of the mitral valve causes blood flow to stop. That means the murmur of acute mitral regurgitation is only present in early systole.
If you found the video helpful so far, please like it and share it with your friends. And if you don't want to miss my upcoming videos, please subscribe.
Do the extra findings we saw in chronic MR also exist in patients with acute MR? Let's go and check it out together. Unlike patients with chronic MR, in patients with acute MR, the PMI is neither enlarged nor displaced. In patients with acute MR, we also have an S3 gala. We also have a soft S1. In patients with acute MR, there is no thrill because the cardiac output has decreased. Blood pressure is therefore low. The pulses are very weak, and we don't have a wide pulse pressure. In patients with acute MR, since it happens acutely, the patients are in poor condition and are in pulmonary edema.